wanted to first thank Linda for the invitation to address you as a group, because this is one, or has historically been one of my favorite target audiences since I'm a basic scientist. I'm kind of an eclectic individual, and I'm trained and practicing pulmonologist who lives of basic science research, and the only patients that I see are patients that have this particular background and because of their lung injuries are destined to have fairly complicated situations. So the way in which I thought that we could put forward something, when Linda first asked me to review this, I was very hesitant to tell her yes. And the reason for that is should be self-evident throughout the presentation. One, because you cannot be comprehensive in describing what an individual that is going to undergo lung transplantation will go through without putting this within some form of very scientific and rigorous context. And so I thought that at the inception of that, I would rather start with a very positive message. Why? Because there may be in the audience someone that be reluctant to accept some of those outcomes. And the way that I thought that I would do that is by addressing Mr. Wilson. Wilson has been, and by his presence here, I'm very thankful, one of our patients within the program at the University of Pittsburgh. And I think that he represents a very good example so that we can do this in a very interactive manner rather than me overload you with a lot of data, which unavoidably I will have to do, and then come to some form of consensus. So why don't you join me here at the podium for a little while so that we can share what has been some of the aspects of your experience, and based on that experience, then I would elaborate subsequently for 30 or 40 minutes without having to give you a whole bunch of lung transplant jargon that maybe you won't very much remember. So since this is a cold, black lung, I would call it now, conference, then give me in a nutshell, what was the risk factor through your occupation that put you at risk for lung injury?
Coal dust.
Coal dust. Very well. And how did you get exposed to coal dust?
Well, I worked at the face, which is the part of the mine that extracts the coal out of the earth.
And for how long did you do this job?
I was in the coal mine for 33 years. 33
years. So when you were discharged from or when you ceased your occupation, did you do it because you were already sick, or it was just the decision that I can keep on going working on this particular line of occupation?
Well, I was sick, and I kept working, and then it got to the point where I couldn't breathe at all.
Very well. So now we say you had a lifetime as a miner. How old were you when you first quit your job?
When I quit?
Yeah.
I was 63 years old.
Very good. So remember that, because that may be important. So you're 63 years of age. You're already you describe it in relatively bad shape.
Very bad shape.
So how limited were you at that particular time point?
At 63, my job was I would walk the belt lines.
No, I'm not talking about your job. I assume that you retired, then you had these medical
I retired
issues.
Because I couldn't breathe.
Correct.
I couldn't walk.
So how limited were you? Were you very short of breath at rest?
Very, very.
Were you using?
I was on oxygen.
You were using oxygen. How much oxygen?
Whatever they give you them little packs.
Yes, but you remember flows? Just
no.
For an
it was as high as it would.
Good. So simple actions like going to the restroom let you and render you exhausted.
That's right.
Very good. Did you require hospital admissions frequently after that? Twice. And then the issue of lung transplantation came to you as a last resource.
Right.
because your physicians clearly told you we got nothing else to offer.
That's it.
Very good. So you came to the program, and in a very, very short manner, describe to the audience what was your experience? What did you go through? And who did you meet at this particular program?
Okay, I'm taken to UPMC Presby Hospital for a week, well, probably 2 to 3 weeks. There's extensive testing just to get your name on the list if they accepted you. And they did the PFTs. They even checked teeth. Anything you could think of, they checked you for. I never had that extensive a physical whenever I went in the service.
Do you have teeth? You have teeth?
Yeah, false ones. They even took them off of me, my regular teeth, because they was afraid that I would have infections that would start a rejection. Anyway, I met Dr. Paluski. He was one of the doctors at UPMC. Dr. Bermudez, he's the one that performed the surgery. And what happened was, once they was doing these tests, my wife and daughter was there, and the morning of the 22nd of February, I was accepted for lung transplant list, which would, of course, I would be at the bottom. Well, at 12:30, I told the doctor on duty that I wanted to go take a shower. Well, whenever I went and took a shower, I had a heart attack. So they had a hard time reviving me. So then that's when Dr. Paluski took me from the bottom of the list to the top of the list for transplant. And on February 23rd, Dr. Bermudez told my wife and my family that they had found lungs. After that, I had the transplant, and I'm a pretty lucky fellow.
Very good. So after you're discharged from the hospital or from the operating room and all the critical care aspect to it, how quickly were you able to come out of oxygen?
Let's see.
Just last month.
Well, a lot of it I don't remember.
Yes.
And
which is good.
Yeah. Because it hurt.
and then the second thing is currently your performance is very good.
Yes,
I mean,
I
you're
can walk.
addressing all this audience. I noticed that you've been buying goodies.
Oh yeah.
Investing your money, and you don't appear to be particularly distressed. Very good. You have done your deed. Go sit down. And so now rest with me the responsibility of put this within a bit of scientific context. And I'm trying to do that in a non-biased manner, obviously. And if I accomplish 2 or 3 of these aims, then I would consider that my participation had been a success. I do not have any significant conflicts to disclose, save the fact that I am an NIH-sponsored researcher, and for that I'm also very, very thankful for the last 30 years of my life. Now, the goals of transplantation then are self-evident, and he described them very beautifully. A, you shall be able to prolong life, but not life that would be meaningless, but rather life that would give you a second chance, so that your productivity will be reestablished and your contribution to society as well. And so, very importantly, would be to improve the quality of life, not just symptomatically, but rather at the level of the physiology. Lung transplant, as almost every other organ, but especially lung, is a relatively new modality on therapy. Certainly was not available when I was a medical student. And I can tell you that the first lung transplant was performed at Toronto General, a fellow that I actually know by the name of Joel Cooper, who performed it very successfully in a patient with advanced COPD. And from that time, it took approximately 10 to 15 years for lung transplant numbers to really, really take off. And so if you look at these numbers, we, for more than a decade, almost 15 years, were standard at approximately 1,000 lung transplants per year. Now, you need to remember that this data come from the International Society for Heart and Lung Transplantation. And therefore, they represent not just the United States, but very, very likely the entirety of the world community that reports. Outside the United States, only Europe and to some extent China and Australia contribute with significant numbers of transplantation. So lung is one of the organs that have been at the end of all the solid organs that are being transplanted. The other aspect that is important with this particular graphic is the fact that you notice that we had moved in terms of the way that we perform lung transplantation. So right around 1993 or so, we realized that what is taking this, or what is really halting this particular program, is the fact that sooner or later you're going to encounter a problem with rejection. That has not been resolved for long. And therefore, it's better if you are given two organs, because your residual function will be better spared and your chance of surviving longer. And therefore, most centers had moved from single lung transplantation to double lung transplantation. But we are in a very good ascendancy. And over the last decade, we had been able to move that number or to duplicate the number of lung transplants. Why? Well, the community had been more sensitive to these issues. Not only the number of individuals that consented to become donors had increased. Pennsylvania is particularly savvy about that, and your driver's licenses will attest to that. But also, from the perspective point of view of the physicians, we had been better able to preserve an organ. Part of the problem with the lung is that, in contrast to, and now you have seen it all on TV, they preserve these organs in ice, and then you move them. The lung doesn't work that way. And only very recently we had understood that at times you have to actually preserve the organ in situ, so that you collect the organ while it's actually being perfused with blood that is sustaining appropriately the heart function of performing that. Because when you clamp the circulation and then you reopen following the anastomosis of the organ, there is fair amount of sort of a stress for this organ, and the function is not very good. So those issues are now at the forefront of the scientific program. The second aspect that I want you to see is that, in contrast to, let's say, heart, where there is today a very large preponderance of transplantations for congenital complexes diseases, lung does not follow that particular parameter. And so the vast majority of the individuals that we are currently transplanted at over the age of 40. Now, that brings the issue that by default, you're going to have significant comorbidities. Why? Because it is time for coronary disease, for diabetes, and a whole host of other issues to appear. Therefore, this is of importance. And I meant to ask you, how old were you at the time of transplantation? 63. Very well. And so you notice that if he would have been transplanted during that 10 years ago, then his chances would have been much lower of actually being accepted at a lung transplant program. But over the last decade, and this number is bound to change, then we have assumed the challenge of transplanted individuals at a much older age. Therefore, this is an ongoing discourse that is important for you to remember. Now, why is that important? Well, it's important because we, as a community, have learned. And with that learning, came the fact that we are now able to move these curves, which meant that if you got a lung transplantation during 1985 and 1995, your chances of surviving about a year were probably less than 80%. Today, most lung transplant programs will quote a number for a one-year survivability, and this is important for you to remember. Perhaps this is one of the pearls that I can give you, is that timing to transplantation is very important. What he described was the fact that he came to a lung transplant program and was accepted, what we call listed, but was not immediately placed for lung transplant. Around 2005, or until 2005, the practice of lung transplantation was that once that you were accepted to a program, you accrue time in a waiting list so that eventually you got transplanted. That is catastrophic because that doesn't account you for this kind of acute exacerbations and so forth. And therefore, that needed to be revised. And So that number meant that as a result of readjustment and better surgical techniques, over the ensuing decade, the outcome of lung transplantation had improved quite significantly. We're still losing patients by a significant margin, meaning 50% of the patients might not survive 5 years. But that is the state of the art of lung transplantation as a whole. Now, what you have matters. How you come to be a lung transplant patient is very, very important. And I will describe this to you in detail. The numbers of individuals that get to be transplanted in all around the world are very much encompassed by about 5 diagnoses, of which one, cystic fibrosis, you recognize as a genetic disease. The other ones are much more difficult. IPF, or idiopathic pulmonary fibrosis, is a very serious disease. That's the disease that I handle. And I can tell you that patients with IPF without lung transplant had an average of 3 years of survival from time of diagnosis. This is worse than any other tumor that you have out there, with the exception probably of lung cancer. And until now, we got no way of improving that survival curve with any medical therapy. COPD, on the other hand, had a better rate of survival, but is so prevalent that lung transplant programs, by default, will be overwhelmed in favor of COPDers. In contrast, idiopathic, the pulmonary arterial hypertension patients had a difficult time because they're much younger, yet their chances of survivability are much lower. So timing of those patients is difficult within the systems. Where is coal miner pneumoconiosis then, or the equivalency of that within this overall data? Well, you notice that it will fluctuate, and by numbers we cannot achieve the large preponderance of COPD or idiopathic pulmonary fibrosis. And so they are categorized within this other pulmonary fibrosis-like of the patients. Notice that only accounts for a very small number or percentage of the total of the bulk of patients that are ever transplanted for any indication. This is our own data. I moved from Tulane, where I was an associate professor at the time, to come here. The Simmons family had, Mr. Simmons' wife had died of IPF, and he made a sensible donation to the University of Pittsburgh to establish a center that will characterize these patients. And this is sort of what we had done from 2000. It was actually September 11, 2001 that got me in Pittsburgh when I came to interview to basically now. So for 13 years after that, this is what we're able to report. We have very thoroughly enrolled and characterized and given clinical treatment to approximately 3,000 patients, of which the preponderance of these patients that have pulmonary fibrosis have idiopathic pulmonary fibrosis. But notice that it is not rare for us to have a very significant amount of individuals that have respiratory complications as a result of their occupation, be that hypersensitivity pneumonitis or, like in your case, dust-induced interstitial lung disease. Does it matter why and how you get to become a lung transplant patient? Absolutely. Why? Because that determines your ultimate outcome. So this graphic is relatively congested, but if you follow two of these indications, I already told you how they permeated or determined the eligibility. But if you follow the patients that have IPF, and this is an enormous amount of data, 7,500 patients transplanted for lung for one single indication is an enormous data, then you realize that those patients start about the same chances at the very beginning following lung transplantation, but by approximately 5 years, they are already at the bottom of the survival curve. In contrast, COPDers enjoy much better responses early on, and it's only after really late that these curves become relatively equal. So I would suggest that if you are going to judge the successful of a lung transplant intervention, like the one that Mr. Wilson had undergone, you better be able to put that within the context, and within the context of a specific disease, be that of a COPD, be that of a fibrotic patient, if that indeed is what is, for the most part, dominating the coal mining pneumoconiosis in this case. The other aspect is that, and I have described this for you already, you disclosed for us that you had undergone lung transplantation receiving the two lungs. So this has become the trend for almost every indication because it certainly improves the outcome. So in adjusting current data to historical data, you have to have this within the context. How were the patients treated? When, in the time of those 20-something years in which we had been transplanted lungs, were the patients assigned for lung transplantation, and how was the regime? So what procedures did they get? How were they treated for their immune suppression? And what kind of organ transplant did they get, single or doubles? This is our own data. We are one of the largest centers in the country, or probably in the world for that matter, in terms of lung organ transplant. There's only, for your information, about 5 to 6 centers that do more than 100 lung transplants per year. Within this geographical area, you have the Cleveland Clinic and ourselves in that category. So to that effect, you shall feel somewhat privileged. And our experience had been that, we no longer do heart lung transplants very oftenly. That has been the exception rather than the rule. Single lung transplant we had abandoned a long time, except in certain cases, and I will, those are specific indications. So most individuals that will now characterize will receive a double lung transplant. Then the issue is has that made the difference? And the answer is yes. This is compiled data, right, for all cases, again, over 17 years. And look at those numbers, very robust numbers, 40,000 close by. This is the combined data. But clearly these two lines, the red and blue, are very, very different, indicating that if you do have a double lung transplantation, your chances of survivability and success, even down the road, 17 years after lung transplant, are much, much better. So, in a nutshell, I'm going to use your situation to address the aspects that are easy without having to burden you heavily. The first question is, oh my God, I'm sick, and so when should a practicing physician send a patient for lung transplantation? And so my rule of thumb is do not waste time. If you believe that your patient is sick enough that it requires complex medical treatment, think of doing a formal evaluation sooner than later. Asking for this kind of help by no means means or compromise or engage you or mandates that you're going to be linked to transplantation. The chances are the opposite, that even under the best of circumstances, getting to a lung transplant is not going to be feasible. And so sooner better than later. Why? Because all kinds of exacerbations are very, very possible. He just described how he had to pretty much be rescued while he was in the hospital. And most importantly, because of the issue of the comorbidities. This takes time to sort out. You know, simple issues like the situation of his teeth, the way that you swallow, issues with urination, GI bleeding, and so forth, mandates an enormous amount of time consumption before you can actually be cleared for a procedure like this. I want to emphasize this because referral does not equate with candidacy and eligibility for that particular procedure, for any transplant, for that matter. And then there is a very fundamental aspect of this evaluation, which is that it should be unbiased. First of all, there should be no economic influence into who gets a transplant and why. This is at the end or at the principle of morality of transplant. Secondly, the fact that this should be done in a very proportional manner. So the way that the system was changed to significant, I disclosed to you that prior to 2005, you basically accrue time. You're put in a list, and if you're lucky enough that you can survive long enough for you to be transplanted, that was good. Well, that system doesn't work. It's not equitable. And so now what you do is you're given proportional ranks. You are older, you got certain disabilities, you require a lot of oxygen, you have no ability to perform, you're a little older, and you got either ventilation issues or your renal function is not very good, then you come to a very high LA score, and that will put you higher on a list. And that is evaluated every time that you go and visit your physician. Because this now is reported via a computer to a centralized facility that is run out of Chicago, that runs the whole computer network for the nation. So your score is actively assessed so that when an organ becomes available, it goes A, B, and C depending on need and geographical location. So that A, there is minimal amount of organ wasting, and B, the sicker patients will get the most likely rank for the organ. So remember this. This is the second issue that I would appreciate if you remember when considering these issues. I'm sorry. Now, are there contraindications? Yes, of course. And one of them is you need to accept that this is a risky proposition. So if you're not mentally prepared as a physician and as a patient to take this kind of risk, maybe it's not in your best interest to undergo all of this. So this is a very serious discussion to have before you actually be approached by a lung transplant program. A, you cannot have dysfunction of major organs. You need a strong heart. In the case of pulmonary hypertension or in the case of pulmonary fibrosis, if your right ventricle is not able to sustain you, there is no way you can undergo this. And right ventricular dysfunction is the one factor that determines survivability for this kind of procedures. You shouldn't have significant renal failure because that clearly overburdens and is a serious complications. At times there have been needs to, and you will see this down the road, to transplant a patient for the kidney before considering something else. And then, of course, advanced cirrhosis and so forth. Malignancy is an issue, and it's an issue because most of the patients, as I disclosed to you earlier, are in a range that are already at a risk for malignancy, but also importantly because if you immune suppress an individual, then you're taking away its ability or his or her ability to fight a malignancy. So you cannot have an active malignancy. Even if it is a skin malignancy, you have to have some certainty that it is appropriately treated. For more complex malignancies, then the rule of thumb is you have to be free of cancer or a cancer survival for about 5 years. Obesity is an issue. It's an issue because it's very, very difficult to perform a procedure in someone that is that heavy. So this is a big issue that needs to be addressed mostly before lung transplant. So is malnutrition, because if you're very malnourished, then chances of you overcoming all this trauma and so forth is very, very difficult. Infection. This is a no-no for almost every organ transplant. And here we are talking about the fact that I will police you personally. Why? Because it's a disaster. To go through what we have to go, to put a patient through what he or she needs to go, and to have you coming back to tobacco is just very hard. So most patients assume that it's just the fact that you smoke cigarettes, but no, they will have you avoid chewing tobacco and being exposed to all kinds of tobacco. And believe me, they will test you at one point or another. And then, of course, you have to be mentally strong and have very good family support to overcome this. So this is basically what you need. This is not a single individual. This is not a one-physician operation. This is a community situation. The university has decided that it's in our best interest to have transplant programs. That's the reason I moved here. And so this requires a very strong cardiopulmonary and critical care system to support a patient through the actual procedure, a very skilled set of individuals that are knowledgeable with hands and techniques, and then a very strong institutional commitment. What do we do? Well, he already described. At UPMC, and this, I'm putting this here just for your information. This is not written in stone because almost every center will have very individualized protocols, right? But what you should tell your patients is that they should be prepared to live in close proximity to a place like this. West Virginia is reasonable, Ohio, and so forth. But if you are outside the state or the city, we had many patients that had actually to have to relocate in order to be transplanted. So the actual evaluation is about a week sort of work with all kinds of tests. And many of them will be relegated to you as a homework. You will go to your physician, have the colonoscopy, have the endoscopy, have all of this, and then send the results back. So this is a very active communication. And then a number of other issues that will be further individualized to the patient. The actual transplant had moved, as I described for you, from single to double transplant. And so you will recognize that because many of the patients will have either a single thoracotomy or it will have a clamshell in which literally you got the mouth of a clam, because now you have to be approached and opened completely so that now you be operated from that side. We favor what is called a minimally invasive approach with relatively small trauma to the chest because we find that with this kind of approach, the patients do better. Treatment for pain and so forth is so much more limited, and then your actual clamps and so forth are much easier to remove. And this is the result. That's an actual picture from one of our patients. This is not a picnic. This is a lifelong engagement. And believe me, everyone will have complications. The patients, ourselves, and so forth and so forth. And those complications, for the perspective point of view of the patient will be either that the graft suffers dysfunction. I will review that briefly for you. Infection. Why? Because we have to take away your ability to reject the organ. Therefore, you're not going to be able to fight any infections. And rejection itself, as well as the comorbidities. So I'm taking too much time. Let me just tell you this. This is data at 1, 3, and 5 years, and you will notice that within the first year, 60% of the patients will require hospital admission following lung transplant. Why? Because they had infections, or because they are rejecting, or because they had some other medical complication. That number progressively decreases, but still by 5 years, 40% of the patients are requiring some form of in-hospital admission. How is rejection defined? So, well, you can reject very, very acutely, right? As a result of, your surgical procedure, or what is a very difficult nut for us to crack until now is to have chronic rejection. And so you can reject right immediately after surgery. That usually don't happen as much. But what is very, very preponderant is the fact that within the first year, there is acute cellular rejection. That usually is related to the mismatch of the organs or surgical complications. But what is more threatenful is the fact that as a result of your successful lung transplantation, the organ incur in chronic rejection, a symptom that is mediated via an immune attack to the airway that is called bronchiolitis obliterans. This, by the way, had become so pervasive that today is one of the first indications for lung transplant. Therefore, a patient that has been transplanted will be retransplanted. And that means that the numbers of retransplantations for lung is quite significant. I don't know how acquainted are you with airways, but it doesn't take a physician to know that this is certainly not conducive to good respiration. This is an airway that is completely destroyed, is invaded by all this inflammation, and the epithelium is all sludged. That is chronic bronchiolitis obliterans, chronic rejection. And we characterize that as according to how decreased or how limited your flow is. And it goes from 0 to 3. And this is a serious business. Therefore, we tell the patients, our patients, that in order to approach this, we ought to be informed. And we are one of the few centers that perform what is called bronchoscopic surveillance. I don't know how often have you been bronchoscoped, but I assume quite oftenly, initially during the first couple of months and years, because we want to get biopsies to make sure that we're not missing it subclinically, meaning that Mr. Wilson is rejecting without us not being able to pick it up because he still has good forced expiratory volumes, and therefore his FEV1 is not decreased. And if it is, then the problem is how to balance this. Because the treatment for rejection is immune suppression. And the more you immunosuppress the patient, then the higher you are increasing the risk for complications, both as a result of the fact that the patient now is more susceptible to infection, but also because these particular strategies have significant pharmacological problems. Risk factors, though, need to be attended a priori, and they come at the time of selection because of the CMV status. I don't want to bother you with that. It will take a whole talk to address that, but also for aspects that we're coming to understand and that are very, very important. A, that the lung is an organ that is subjective at one point or another by a small microaspiration. So I don't know about you, but I'm sleeping with my head of the bed elevated because everyone refluxes, and I still have to see a patient that has pulmonary fibrosis that does not have some degree of gastroesophageal dysmotility. So this is important, and it's one of the strategies that we go, to the effect that just like your teeth, we had at times decided that it's very fundamental that the patients be addressed for Nissen fund application and stuff like that in order to prevent this issue. And one of the most frequent reasons why the patient is disqualified is severe gastroesophageal reflux that cannot be controlled either medically or surgically. I'm not going to spend time with this. This is more information that you will require, save the fact that as a result of research, we came to understand that certain preconditioned symptoms or approaches appear to improve the ability to do that. So a medicine was described in England about 10 or so years ago called Campa, and is a very powerful antibody that basically takes care of all your T cells. So as it's an antibody now called daclizumab, and alemtuzumab, the Campa. And what that does, it blocks completely your T cells. Basically, you're going to be rendered. You remember that baby that used to be in a bubble? Well, that kind of patient you will become. And so they use that as a conditioned media in order to treat you before you receive your lungs. That single intervention appears to be succeeding and reducing already the number of bronchiolitis obliterans down the road. So that still needs to be tested in a more direct manner. But this is the program that you will see for life if you succeed with this, which is that before you even take breakfast, you're going to be heavily medicated. So you better believe that you're going to derive a lot of calories from your medical medicines because, one after another, you're going to have 3 or 4 medicines to immunosuppress you and a very significant amount of antibiotics, antifungals, and antivirals for you to take. But the idea is that you may survive this, and if you may survive it, then with that you may develop a number of complications. Those complications are summarized here, and I don't want you to think that they are, in my mind, enough reason, judging by your clinical situation, to discourage someone from having lung transplant. Yes, you're going to have infections at one point or another. Yes, your chances of having cardiovascular disease could be enhanced, and more importantly, renal disease. That is described here. Why? Because most of the patients will, at one point or another, from year 1 to year 5, have some degree of renal dysfunction, hyperglycemia, and, of course, I already disclosed for you the syndrome of bronchiolitis obliterans. But everything is going to be better. Why? Most patients that survive a year for lung transplantation have an improvement in the quality of life. So you exemplify that beautifully. You know, coming from a situation where you're not even able to move easily, to be because you're completely out of breath, to just come and address your colleagues, I think is very memorable. And I disclose for you that the ultimate outcome is to reinstate the quality of life. So notice that even though most of the individuals are not working actively or are retired, most of the patients we transplanted are on that group of age, a fairly significant number of them had been able to be or capable of returning to some form of valuable occupation. And that is the ultimate outcome, even if it is just to advocate and agitate. Now, I think that I prepare for the audience at the last minute specific data with cold workers pneumoconiosis. And so you would believe that it's very difficult to find that data. Why? Because in my mind, a lot of these situations had been mischaracterized. This is a retrospective analysis performed out of California, looking at a very, very large registry. And the way that they organized that was to take the data that I disclosed for you and do a retrospective analysis of the number of individuals that were listed for lung transplantation with a potential diagnosis of an occupational lung disease. And they subdivide that group into patients that have silicosis or patients that have non-silicosis. Notice that out of all those millions that I described for you earlier, only 37 patients are registered. So the number of individuals that are being transplanted for these indications are minute. Yet the impact can be so significant. Now, not all comers appear to be equal. Notice that in this study, the patients that have silicosis were better than those that that had occupational lung disease, but a diagnosis that was different to silica. The two groups, though, are slightly different. Not necessarily on age, although the patients with silicosis were slightly younger, but also the fact that the people that were diagnosed with silicosis were fortunate enough to have younger donors. This is an age difference of almost 5-6 years. And I think they disproportionately received double lungs compared to this other group, 20%. Therefore, when they look at the overall rate of survival, it's very skewed in favor of the patients with silica. That surprised me because notice that the number of patients with silicosis were 19. Well, it turned out that I myself took it upon as a duty to examine what was our own population and characteristics. So If those patients came out of the registry, they should have included our own patients. And what I was able to find out is that many of the patients prior to 2005 probably were listed as OLDs instead of silica, meaning they came as pneumoconiosis. And eventually what these patients really, really had was a complicated fibrotic process that was very misclassified. So I went to the registry, I pulled all those tissues and sent them to a very best lung pathologist. And basically everyone had silica in it. And so I think that that paper is somewhat misleading. But the idea here is that we transplanted 11 individuals with silica. And we contrasted that to what I thought was more reasonable, which is that of other patients that had advanced idiopathic pulmonary fibrosis. And in that case, then the lines are relatively similar, but in contrast to the patients with IPF, the patients that were transplanted predominantly for a diagnosis of silica had a much more difficult post-operative outcome. They rejected much more quickly, and I assume that that could simply represent the fact that these tissues are so inflamed that technically is much more difficult, but that needs to be better analyzed. And therefore, few of them were able to survive at the time more than 5 years. So, food for thought, I think. I think that you helped me exemplify a very important problem for this community, which is when you had an individual that is about your age, that has already paid with sweat and health in a very arduous manner, and be injured in the lung for this, is lung transplantation a suitable option for them to have? And so the verdict is still there. I think we had made an enormous amount of progress in this field. We understand that we should evaluate the patients sooner rather than later, identified what are appropriate comorbidities so that therapy be properly adjusted, and whenever possible, then go aggressively and go early on, so that just like you, Mr. Wilson, perhaps there is the chance for having a better outcome. This is just a way of information in case that you ever had any questions. Nancy Pepke is one of our pre-uptake lung transplant nurses, and they're very, very helpful, extremely helpful. And want to remind the audience that we're only able to transplant simply because of the grace of donors. So for your attention, I'm very thankful to you as well for sharing your personal experience. If there are any questions that I'm able to address, I'll be happy to do so. And thank you again for the invitation. I'm sorry, your name? Mm-hmm.
Mr. Wilson, how long I didn't hear how long ago you had your lung? Excuse me?
How long have you had your lung transplant?
It'll be 3 years in February.
Don't.
Yeah, are there guidelines for as far as age is concerned, and if so, are those guidelines current?
Okay, so the guidelines are not set up in stone. and I eliminated a couple of slides from there. They vary very much from center to center. I disclose for you that there are very few centers that do large volume lung transplantation. And this is exclusively on the fact that your ability to survive as a lung transplant program depends on success. And that's true for almost every organ. Your certification, especially early on during the certification of the program, are mandated by being able to show that you're able to produce results that commensurate to what your peers are producing. Therefore, most centers won't tell you, but it's true, will be guided for self-preservation. They will only take an individual that is a clean surgical case, right? Meaning if you had already had an sternotomy because you had previous coronary bypass disease, that is a very big scar that you're going to have to deal with there as a surgeon. Secondly, average folk will be transplanted. You don't want to have a very small person or an extremely large individual in which a lung will not fill completely. And by default, you're going to have an empty cavity. And that kind of situations are what really determines where you go. With regards to age, until very recently, most centers will not consider someone that will be really younger than 65 years of age. So, and I would say most centers will cut off at around 62 years of age. Why? Well, if you're 65 and you get 5 years of life after a lung transplant, you're already 70 years old. The average individual in this country is living approximately, 74 years of age for males? Maybe a little bit more. Females is like 78 years of age. So you're getting closer to that number. And so the incidence of comorbidities are so much larger that it makes it very difficult to justify that kind of investment, both in terms of health and stuff like that, to do that. The other issue is that if you start your assessment at 65, then I have to make sure that, as I described before, timing makes everything or determines every issue. I will ask you, what are your chances of you to survive a year? And if we start at age 65 with a chance of survivability that is greater than 80%, then it is unreasonable to lung transplant you at that point. And so those are the aspects that you really need to consider. Now, if you're a very healthy 65 years old, then it's reasonable. But that will be more of site individual determination than any other thing. I don't think it's written in stone. All right. Thank you very, very much again.